Good afternoon, everyone. My name is Zania Daz, and today I'll be presenting my literature review on Article 2. So, let's get into our objectives. Firstly, we want to discuss pertinent article information, summarize the article and highlight the key points, and assess the article for validity and level of evidence, and finally, conclude with questions and answers. So let's start with some dental humor. The toothbrush doesn't remove 6 months of tartar 30 minutes before your dental appointment. Right, so let's get into our article information. The title of the article is Indirect Pulp Capping and Primary Teeth. Is the primary tooth pulpotomy out of date? The author is James A. Call, and the name of the journal is Paediatric Dentistry. The journal has an impact factor of 114. The date of publication is May-June 2008, and the major topic is Should Indirect Pulp Capping Replace Pulpotomy? And the type of article is a literature review. So the main purpose of this article is to review the dental literature and new research in vital pulp therapy to determine the following. 1. Is a pulpotomy indicated for a true carious pulp exposure? 2. Is there a diagnostic method to reliably identify teeth that are candidates for vital pulp therapy? And 3. Is primary tooth pulpotomy out of date, and should indirect pulp therapy replace pulpotomy? Let's summarize this article. Pulpotomy is thought to be indicated for primary teeth with carious pulp exposures, but research shows the majority of such teeth are non-vital or questionable for treatment with vital pulp therapy. So on the right, there's a picture showing how a pulpotomy is done. So the chamber pulp is removed and replaced with medicated filling, while the canal pulp stays alive, hopefully. Primary tooth pulpotomy requires a vital radicular pulp, no matter what form or type of pulpotomy procedure is used. Teeth with a carious pulp exposure have a low likelihood of being totally vital and are thus poor candidates for vital pulpotomy. For teeth without carious pulp exposures, performing a pulpotomy likely increases the chances of displacing infected dentine chips into the pulp and impairing the pulp's repair capacity. The pulp's repair capacity is excellent when the carious lesion remains 1 mm or more away from the pulp. Formacrosal pulpotomy is most frequently used to treat asymptomatic caries near the pulp in primary teeth. Treating primary teeth with deeply cavitated carious lesions after minimal excavation with glass ionomer control for 1 to 3 months before instituting pulp therapy causes the bacteria to be significantly decreased within the lesion. In vital symptomless teeth with apparent radiographic exposures or near exposures, treating them with caries control will likely stop caries progression. GICC for 1 to 3 months changes the character of the dentine so that it is drier and harder, and the affected dentine likely remineralizes similar to dentine after stepwise excavation. Using GICC as a diagnostic tool for 1 to 3 months in teeth with symptomless radiographic exposures or ones with pain and questionable vitality will diagnose those that can be treated successfully with vital pulp therapy 98% of the time. Indirect pulp therapy has a significantly higher success in treating all primary first molars, but especially those with reversible pulpitis compared with formacrosal pulpotomy. Indirect pulpotomy is also indicated and has a significantly higher long-term success. IPT is less expensive, has fewer potential side effects, and does not exhibit early exfoliation as pulpotomy does. So now that we've completed our summary of the article, there are just a few pictures and diagrams that describe and depict a pulpotomy and indirect pulp capping. So our first diagram shows indirect pulp capping. With picture A, removal of the caries with a slow speed burr, and picture B, the 3 layers of carious dentin. Picture C, showing the pulp capping occurring with calcium hydroxide, and D, placing as improved ZOE material over the calcium hydroxide. Our next picture is a schematic of ferric sulfate pulpotomy, where irreversibly inflamed pulp tissue is removed and it is replaced with cotton wool moistened with ferric sulfate and then covered with zinc oxide eugenol cement and then covered with a stainless steel crown. However, in the former Cresol pulpotomy, instead of having cotton wool moistened with ferric sulfate in the pulp chamber, it's rather filled with former Cresol impregnated cotton pellet, but they both share the similarity of having a vital pulp. So let's assess this article. Given that this article is a literature review, the evidence level is low, ranking at level 2-3. It mainly consisted of background information from other articles. So in conclusion, do not treat carious exposures in primary teeth with pulpotomy or direct pulp caps. Consider pulpectomy or extraction because of the high chance of irreversible pulpitis and failure of vital pulp therapy after a carious pulp exposure. For deep caries approaching the pulp, the choice of IPT or pulpotomy is up to the treating dentist. Use glass ionomer caries control for deep cavitated lesions to diagnose the status of the pulp with or without history of pain to attain the highest success for vital pulp therapy. And finally, avoid the pulp by using IPT for a higher, longer chance of success compared with former Cresol and ferric sulfate pulpotomy. Here ends our presentation. Thank you for listening. And do you have any questions? I'm here to answer.